Pip Brennan is a long-standing consumer advocate. She comes to us from Perth, so welcome from across the country. I really love it when we have these truly national perspectives when we have conferences like this. She's a consumer advocate in Western Australia's health sector, and she's currently serving as the digital health lead for the Health Consumers Council. She's had over 25 years of experience and is currently co-located within Western Australia's Health Electronic Medical Record program, where she convenes the EMR Consumer Reference Group, facilitates webinars and ensures that the WA Health's EMR Consumer Health Charter continues to inform how the EMR is being implemented in WA. And she's focusing particularly on ensuring that digital health systems like EMRs and patient portals are designed with meaningful consumer engagement, prioritising transparency, interoperability and equitable access to health information, all of which are just critical if this is going to work when we have EMRs. Connie is our next one on my list. Connie comes to us from the Uni of New South Wales. She's a senior research fellow in psychology and health systems and populations. Her research focuses on digital health equity and system change, particularly for priority populations, including older adults, women, and people in underserved and remote communities. And she's leading and co-designed studies that explore the use of wearable technology, digital platforms and inclusive health models to promote access, engagement and wellbeing. She's had significant MRFF funding. She's an extremely successful researcher and with over 35 years experience in behavioural sciences. So she's really can bring some perspectives to us on organisational change, psychological research and practical implementation across sectors. Adrian Boscolo is my next speaker on our panel. He is the Deputy Chief Medical Information Officer at Sydney Local Health District and General Practitioner Staff Specialist at Sydney Virtual. So he holds fellowships with the Royal Australian College of General Practitioners, and he is an Associate Fellow of the Royal Australian College of Medical Administrators, which has the longest acronym I've ever seen in my life, AFRACMA. He's a certified health informatician and graduate of the Australian Institute of Company Directors as well. So he led New South Wales Health's first AI ambient scribe implementation at RPA, their sarcoma clinic, and he developed a risk-based governance framework for the AI tool assessment at Sydney Local Health District. So he's served as medical lead, or serves as medical lead for RPA Virtual Hospital's Long COVID Clinic, and co-chairs New South Wales Health SDPR Working Group for Virtual Care and Remote Patient Monitoring. You've got a lot of hats on, Adrian. We're very glad you're here. And last but not least, we have Karen Gallagher. Karen is a dynamic and results-driven professional with over 15 years of experience in social impact and transformation. And she's the General Manager of Strategy and Customer Experience at Health Direct Australia. She's at the forefront of driving innovation and digital transformation in the public health sector, and has a background in business strategy, human-centred design and marketing, and she's very passionate about leveraging technology to create seamless and user-centric experiences to improve health outcomes, and she holds a Master of Design Futures from RMIT. So we've got a very distinguished panel, and I'm really, really excited to be able to hear from all of them. So without further ado, I might just ask the first question, and this is a question for all of you, and it's just first in, best dressed. So we're going to start with the big picture, rethinking health and care with digital health in mind. When you imagine Australia's health system in 10 years from now, What is the most significant digital transformation that you expect or hope to see? First question.
I have the microphone, so
Okay, Adrian, you've got
start.
the talking stick, so you can go first.
I think we need to start with what's on everyone's lips at the moment, which is AI, obviously, and the impact that it will have. And I think for me, working in this space, I see a transition of the data that's happening right as we speak, which is from institutions and governments to individuals. And I can see that as being the biggest change that we're going to see over the next 10 years, because it will impact everything. It'll impact consumer empowerment, the way that clinicians deal with patients, and also the way that we have to design our systems for interoperability and where we sit as clinicians in that ecosystem. I think previously there's been a lot of information asymmetry that will reduce, and I think clinicians need to avoid being gods of the gaps. We need to sort of think about how we can work with the consumers to empower them in that care and be that trust broker, knowing that there's lots of players in this space. There's AI companies, there's government. Who navigates all of that? I think there's a big role for us as clinicians.
I think if it's okay as a consumer, I'd love to follow that up.
Yeah.
I totally agree with the information asymmetry. As patients, we have to make life-changing decisions, but usually we don't have much of an idea what the actual decisions are about. I guess I'd love to see a quantum shift from the stubborn 60% of people in Australia have poor health literacy, and I think that's an inevitable result of that information asymmetry. So just imagine we have, by 10 years' time, we already have implemented a My Health Data Act, and that act has made sure that consumers own their own data. So I think that that is absolutely key, that we are active and not passive partners in our healthcare. Also, what I think that brings in is preventative. We just literally never invest in preventative in the way that we could. We do not empower people early enough. Everything's falling off the edge of the cliff at tertiary, hospitals. Always get the money. No matter what we do, it just always goes back to that. And I think once we start to address the information asymmetry, put the tools in people's hands, start seeing people not just as an individual, but someone that sits within a support network. Yes, maybe this 90-year-old can't see the phone, but their 60-year-old child can. And for God's sake, don't not give them the data because you think it's going to be inequitable, but start working, to ensure that the information asymmetry is addressed.
Is that good? Yeah. I actually want to build on that.
Make sure,
okay.
Make sure you talk right.
I think you're right on. It's like I think we really have to start very patient or person-centric, and before a person ever becomes a patient, because if they have data, if people know about themselves, if they are empowered to actually not just have access to the data, but to use that data and to benefit from it, then I think we completely shift the dial and ultimately lower our health cost because we're looking in the prevention side of things. The other thing I want to say is I hope when we look 10 years from now, we're not still talking about closing a gap, but we're talking about that we do work in a way that means we don't create the gap in the first place. And I think that is by starting with the people with the most complex needs and the most complex situations, because whatever we create for those people in those situations will work in Sydney and will work in a hospital. And I think it's a mind shift to move away from thinking technology first. If we go people first and complex needs first, everything else becomes a little easier.
I'm going to build on that again. Gosh, so I think we're all heading in the same direction, which is great. So, when you think about what's the outcome, like what does the digital transformation build and that idea of person-centred, we did some research a couple of years ago when we were looking at what's the future state of Health Direct, and a lot of our work is very focused on I guess almost like information in people's hands and advice that can help them to access the health system, but also to take care of themselves. And when we did that research, it really you start to think about that so much of the way we think when we're in the health system keeps orienting back to the health system rather than the person system, which actually orients around their home and the concept of health rather than illness. And so I think when we start to think about what digital transformation starts to enable, and we're starting to see this with the virtual pathways, you don't have to go to hospital, you don't have to wait for hours. We start to think about AI. How can AI help us make tools easier? Because I think when we're talking about data, I kind of, I know what data is, but I sort of don't unless it has a meaning to me that matters to me and I can access it in a way that I can be like, oh yeah, this is what I should do because of this, or this helps me enable a decision. And so I think if we start to think about the concept of care and the concept of home, then we start to think that digital transformation might actually be able to centre around that. How do we help that? And I also think that would both be really amazing for consumers, but also really good for the health system because we don't have any space left. We haven't got enough workforce. So, so I think that's probably how I would like to see digital transformation as an outcome would be how much more of the care in Australia takes place at home by a consumer being not just equal, but the leader. Yeah.
We don't want more services, we want better health.
Yeah.
Yeah, what a great motto. Myron, did you have any initial thoughts?
The only thing that I could really add to that, and I'm glad to see that the discussion is really outcomes focused. I was just going to say, from the implementation perspective, it's the end of pilotitis. So did a bunch of reviews recently, just amazed is the amount of feasibility studies and acceptability studies, and we just want to try stuff out, but kind of moving from trying stuff out to actually implementing for an outcome sort of focused implementation, and then I guess the thing that I've been focused on recently is institutionalization. So we run trials, we know these interventions work, we know that they improve patient outcomes, we know that they're cost effective. And then that last piece is, okay, how do we convince the LHD to put the money where their mouth is and actually fund something as a sustainable service that we know improves outcomes in the long run, saves them money as well. And I think that last piece is kind of where I'd like to see. And now it's 10 years and very aspirational words, but I do think that's if I had to articulate like a goal for the system itself, I think that would be the final piece. Yeah.
It's a very admirable goal and really important. So I think, it probably will take 10 years to get, it's getting government to do things differently as well, isn't it? And policy. So we might move on to co-design, the idea of co-design. And I've got a question really for Adrian. And this is about how do we make co-design easier rather than just expecting more of it? And I know this is an area of particular interest of yours, Adrian.
Yeah, thank you. It's and it's so important as well because I think we often talk about co-design, don't we? And then
we do. It's not really co-design.
It's the buzzword of the day, and we sort
colonised term.
Yeah, and it's kind of just tacked on at the end, I've found, and embedding it is so hard. And I get it. Like it takes time, it takes effort, it takes commitment, and not just at the consumer level, but clinicians level as well, because we're asking clinicians to come off the floor and participate in these design workshops and that sort of thing, and often there's not a translator there to sort of make sense of this, and so they're having similar conversations again and again. I think we do need to have a shift though, sort of coming back to what we all started this with, that the dynamics of care have changed and we need that input from consumers and clinicians from the outset. It can't be, we've designed this model, what do you think? It needs to be right at the beginning to say, hey, we're getting this done.
What problem do we want to solve?
Yes, exactly. And just sort of flipping this a little bit, if we think about what some of the risks are, is that the burnout comes and the change fatigue comes because the problem wasn't necessarily the highest bang for buck to begin with. So I think we really need to start with clear use cases, work out what's feasible, and then get people in at the outset. And then they won't be disappointed when they're like, you promised us this and it didn't come through. We're on solid foundation.
Could I just pick up on that, and also what you said, Pip, that kind of what is the problem that you want to solve? What's the challenge? Because when I started my research, I was looking at social media and health messaging and that sort of thing, and the older Indigenous women that I was talking with said, "What we really want are wearables. That's what we want to talk about." So that I made that shift, and the acceptance is so high because it was their idea.
Yeah, and I was talking about, sort of partly with the first question, I was thinking, what would I like to see in 10 years' time? I would like to see it be absolutely unthinkable that you wouldn't co-design. I was thinking the first presentation, which I really liked at the end, there was no thank you to any kind of consumer or any kind of consumer group. We're absent. We're not the ones buying the technology. We don't have the power. But in fact, we are supposed to be, it's supposed to be patient-centred, but in fact, we are usually the bottom of the list, and the clinicians are above us, and then there's the funders, and do you know what I mean? So I just think that whole thing about co-design. And I would also say, I hope this is not confusing, but co-design isn't always the right tool. Mm-hmm. It's okay to consult. It's okay to involve, and sometimes you want to co-design. But I do understand the time frame. If you're going to co-design, you need decent budget and you need decent time. But you don't always have decent budget and decent time. If you've got something like, so I'm from the Health Consumers Council in West Australia. There's one here in New South Wales as well, Queensland, Tassie and so forth. You develop the relationships over time, and you can do the quick and dirty consultation without undermining that relationship. You have people that really understand, they're part of the team. So co-design can be really important, and certainly I think you need to work on what the problem is from the beginning. But it can come in a lot of different ways and shapes and forms. But it starts with, you've got to think about it, you've got to plan, you got a budget for it. I have seen research budgets where there's more money on stationery than consumer involvement. Don't let that be your research application. So, I just think co-design's just part of the story.
I know you've probably got other questions, but it's just interesting. Do you want to keep moving on? Coming from a design, I don't know if there's anyone that's designed Adeola is in the room, and so. When we're thinking about, in particular in Health Direct, we have 9 governments. We're working with 9 governments, and then there's multiple. There's originals. There's like, what's the role of the organisation, which might be is we want to leverage the assets for 9 governments so that everyone across Australia could have access to advice and the right pathway. We want to build scalable infrastructure, and so from a design perspective, I go back to that idea of desirability, viability, and feasibility. And often I think when we're talking about co-design, we treat consumers as if they're only part of the desirability bit. And so when we're talking about scope, we don't give them a clear understanding of some of the restrictions potentially in play with the feasibility and the viability in a complex system with restricted funding. So I think that when we're involving consumers in our work, to your point, Pip, we've got to be really clear on what the scope is and what we're asking and what participation they might be able to have or not have in decision making, or where the decision is going to be made. But I also think that we can provide the consumers more understanding, especially if we build relationships, with what are some of the constraints we're operating here. Like we're not going to be able to completely change our tech stack for this localized issue if that's the role we play in the system. And so I think that's also really important. And internally, I'm trying to grow the maturity of our organisation in how and when they use that word, but also that we can have consumers understand these concepts. Like, we're intelligent people, I'm saying as a consumer here because I'm also, a carer and stuff. So yeah, I think that's really important as well, is to be really clear, but also to involve consumers in the other parts of that Venn diagram.
At all stages, at all levels is what I say. Consumer involvement at all stages, at all levels.
That would be great.
Can I ask a follow-up question? So, we're talking about this concept of digital health promising empowerment for all, in practice for communities, but we know that there are some communities that are historically marginalised. So the question here is, how do we ensure that that everybody, it is for all? What are strategies? How do we do that in our work?
I mean, I really do think a lot of it goes back to some of the things we've already said. The inclusiveness at the early stage, I think, is fundamental. And I think so often we think we'll build for the middle, and then we'll try to adapt to the edges. And it just doesn't really make sense, And I go back to the whole concept of universal design, which some of you it came out of architecture. And the idea is, you build a curb cut. Do you know who benefits the most from curb cuts? Parents with children, strollers going through. But they're built for, people who use wheelchairs. But it in no way disadvantages a person that doesn't use a wheelchair. And that is to me the only way that we really are going to create that kind of true empowerment for people, because they got to be able to use the stuff.
I think sometimes it can be helpful to stop thinking about people that are hard to reach and think about people that are hardly reached. We're actually not reaching out to them, as you were just talking about that example of when you switched to something that actually worked for the community. You had all that wisdom and all that lived experience at your disposal.
If I could just jump in, I think the word that comes to mind for me is the stake, making sure that people have a stake. And at the front of the process, I think that's co-design. And that's a sort of buzzword, I guess, in that space. But also, I think ownership is really important. Like with the work I've done with social enterprise, and the one I'm kind of toying around right now is the biobank. So when health data is generated, you can actually have biobanks that run as social enterprises. They own the data, and people own their own data, and in doing so, they own a piece of equity, literally, in the biobank, which is running as a business. And that data can then be sold to different entities for whatever use, with, of course, the consent of the people who own the data. But it is kind of and this is happening in the EU, admittedly, not in Australia, but a kind of, as a hypothesis that you can test of, does this work socially? Are people okay with sharing their data because they do own it? And if they do own it, they have the right to decide on where it goes. And that's what a social enterprise is. It's this idea of, a business and having ownership in that. I think that's probably the end of that translational process. It starts with co-design, and ultimately you put this thing out in the world that is owned by the people who are involved in it as a part of it.
I hear that, but also I think what's at stake usually for consumers is their life and the lives of their loved ones. We have a huge stake. So whether it's a full-on co-design or a consultation, you'd be surprised at the number of dull things we turn up to in droves because it's really important to us.
Of course.
Back to the question that you asked as well, like the kind of concept of the digital, I guess, digital access, digital equity, that's concept of digital divide. I think I've already heard two comments on this that really, you said before you spoke to some Aboriginal women and they were interested in wearables. And you said the 90-year-old has a 60-year-old. And so I think what's really interesting is I think we need to update our concepts of digital literacy. And Julie here did a study last year on ChatGPT, and the people that were using ChatGPT were the people that we're probably not maybe meeting the needs of in our traditional health system right now, possibly because we're not willing to adapt and take on risks. Meanwhile, the most likely people to be using ChatGPT to look at their symptoms are people where English is their second language. So, I think we kind of, I think we should be looking at digital as this opportunity to create equity and democratisation of a system that, rather than saying, we have to make sure things are so simple and so easy, let's not even go there with this priority group. Let's, as you said, let's talk about social media because we think that might be the thing that's the answer. It's like, actually, no, let's talk about wearables because that's what you're interested in. So I do think that we've got to make sure that we aren't holding on to concepts of, I was saying before, parental concepts, patriarchal concepts, and actually, like, if people are already doing this behaviour on their own, let's catch up. Yeah.
I think you're so right. And, following on with that research after I was qualitative work that I was doing with the older women, I did a large survey. 92% of the older Indigenous women, mostly living in remote and rural locations, wanted to use a wearable. I mean, when do you get 92% of anything? So it's like the interest is there.
Yeah, I think we need to be very aware of our own preconceptions and, try and leave them all at the door, particularly when we're working with populations that we're not from that culture, So, yeah, I'd completely agree. Just following on from this idea of, chat GPT and thinking about artificial intelligence, and I was, as expected, it came up in the very first phrase, I think, of this discussion. I was expecting it to come up quite often. It is moving incredibly fast, which I think is very challenging on a number of levels. But the question, I'll pose it initially to Adrian, but obviously it's to the panel, is really about how do we set up guardrails to ensure safe, responsible, transparent implementation in clinical care?
Yeah, I think this is the key, isn't it? So for me, I've thought of obviously a lot in this space, and I think initially we were all kind of trying to get our head around where the edges are, where the risks are, and everyone was a little bit sort of just watch and wait and sort of thing. I think we're moving forward now, and I think we've got some models to think about this, and I think cybersecurity actually gives us a good model where it's this idea of defence in depth. So you've got layers of different levels of governance and different levels of protection. So, at a high level, you want to prevent errors, and we know how we can prevent errors to a large extent in AI, and that's things like model validation at a local level. Is the model that you're using, for example, valid on the patients that you're actually treating? So we need to validate that. And then we need to surveil. We need to look for signals, sentinel events, that sort of thing, that tell us that the model's not working as intended, or there's something that's wrong. And then the next level, we obviously need to respond. And I think, a good question for me is, could we turn the system off? If we build a system where we can't land the plane, so to speak, that's problematic. So we really need to think about how do we respond both at an individual level, how do we train clinicians and users of these systems to be able to be aware and say, hey, that's not expected. What's interesting for me is that these tools create so much trust now because they're so convincing. But I use them all the time, and what's interesting is the more I use it, sometimes it'll just do something completely crazy. And I'll just be like, what? I'll be like, oh, they've solved the hallucination problem, they're getting so much better. And then out of the blue, there's nothing there. And it's because I use it so often that I know where those edges are. And I think we need to get users involved and clinicians at an early level using these tools right from their training so that they know what the guardrails should be and they don't just blindly trust them. They have those what the moments. And so I think that's that defence in depth level. And I think finally just being able to use feedback and change the system based on that feedback. So once an event's happened, do we have the governance structures in place to look into what happened and say, we need to fix X, Y, Z, we need to do the training, we need to fix the model, and then keep doing it. It's not just off we go, we're live, see you later. We need to constantly check in.
Will we be able to do that is my question. I'm someone that's done quite a lot of work around medical devices. We don't track those very well. We don't often know which medical devices have gone into which bodies. Are we going to be able to do that? And I guess, one of my questions as a consumer advocate is, are we developing the AI for public good, or are we developing the AI for profit? So I always get excited when I see Health Direct because I know it's for public good. And when it's something like Health Engine, I feel uncomfortable. Sorry to be so rude.
Can I just quickly pick up on that? Because I think that's a key question. I think the answer is we need to go slowly, and we need to just say there's so much, we all know there's so much hype right now in AI. Everyone wants to do this big, I get these constant requests about this big next thing, and they're wonderful. That's great. It's a great idea, but hang on, what's the use case? Can we be sure that it's safe? Let's start small and iterate, because the risk is all the things that we talked about before, the change fatigue, the errors, the disempowerment, that happens very quickly. So usually I've got a strong filter and say, no, unless we do X, Y, Z, or unless we can do that, but we need to embed it systematically. And I take your point about the big tech. I'm just as cautious as you are, maybe, but we need to be really wary and where they fit into this. But I would say we need to lean in and sort of work with them to make sure that we're in the conversation.
I think there's this real paradox. Like, we need to lean in but go slowly, but meanwhile consumers and ChatGPT Health are leaning in and going quickly. And so I think there's something around that about what is our current risk profile, who is being missed and is experiencing large levels of risk that we're not tracking and not looking at all, and what is the risk at the moment. So, for example, we know that people can't always access a fast health appointment in their own language, in their own dialect. Like, that's an existing problem. And you can get TIS, you can get a free service, but they may not be there in the middle of the night when you need them in your dialect, and the quality of that may not be perfect. I guess the question is like, what is our tolerance for better versus perfect? And where do we go, okay, this is so, because I think that the part of the problem with this as well is that all of the liability in the health system rests with your clinicians and your government. But for ChatGPT, it just doesn't in the same way. So consumers can engage with that. But consumers in doing that are also accepting a risk. But they're also, and actually I'm just stealing words from one of my team members here, it's like, what is better? You know, what's the benefit? And if the consumer's saying there's a lot of benefit here that's outweighing my concept of risk, then we probably need to start thinking about that as well. And then how do we communicate around that risk, and what does informed consent look like in the models that we're building and that we're asking people to engage with? Because I've seen one for hip reconstruction recently. This is all the risks you're agreeing to for informed consent. I'm like, holy crap, they're saying I might die on the table, you know? But I haven't seen that for some of the AI stuff where that's being used in the same kind of way. So I think that consumers can, again, be kind of part of how slowly do you want us to move? How fast would you like a really safe version of ChatGPT that is government-backed?
I personally would love that. I mean, I pushed quite hard for my health record to be a government app and not a Health Engine or other third-party app. And I'd love something that I know is for public good, not profit.
Can I just extend this discussion a little bit further? You know, we're talking about AI and, you know, consumers becoming digitally literate and being able to be critical thinkers when they're engaging, which is it reminds me of when the internet, which I'm old enough to know when the internet first started. So I'm not alone here. But you know, that was the first foray into, you can suddenly access all this information that you just couldn't do before. And we seem to have survive that and develop systems. I think AI it's testing us in the same way from my perspective. But you know, how do we build an AI capable workforce? You know, what training is needed for our clinicians? And you know, given that you're sitting in the health system there, Adrian, you know, what's happening for clinicians and how, because it's huge. It's like a transformative moment, I think, in healthcare. Yeah,
thank you. So I feel very passionate about this space, and yeah,
good, I mean, that's very good.
You know, we're living through a tech revolution again. Yeah. It is the internet. It's happening through. I never thought I would live through it, and you know, to sort of see these new models and all this tech coming through like daily, weekly, it is. You know, you do get whiplash, and you just see the changes that are coming through. So how do we prepare our staff for this? How do we train clinicians, and how do we prepare consumers for it? I'm a big fan. Look, I've done a lot of study in my time, and I've been talked at a lot, and I feel like it's not a good model for this. I think we need to get it into people's hands. What I realised, so I give a talk to medical students. I don't know if there are any here, but I've learned about medical students that they're a sponge with a filter. And they're looking at everything that they suck up through the lens of how does this help me to get through my exams and get through medical school and that sort of thing. It's like, great, let's use that filter. Let's give them a prompt workshop where they can work out how to use these tools more effectively, and also show them an AI scribe where the AI is transcribing something that's completely wrong. And so they say, whoa, hang on, that's not all that it's cracked out to be. Also just breaking down the barrier to say, you don't have to be a tech person to get involved in these tools and to contribute meaningfully. I often, you know, meet people and they're like, oh, that's not my field. I'm like, no, it totally is, because technology needs to meet you where you are. You don't have to sort of work out and have to work hard to make a tool work. If you're struggling, it's because it's a tool problem. And I know Adeola in the human factors, you know, we've done a lot in this space, because if something that's not workable or it's not the user interface and the user UX is terrible, the clinicians will just turn off and they won't engage, and that's where the problem starts, because they don't use the tool, and more importantly, they don't get the feedback for when it's not working. So it really we need to break down that barrier and say everyone is a tech person, or you can use technology, and that's part of your role going forward. It's not nice to have. And I completely acknowledge that people feel very strongly about AI in different ways. I totally get that, I respect that. But the reality is it will be part of our lifestyle and our health system. And as clinicians, you need to be able to use it. And so I think, yes, get them using it from day one is the key for me.
You know, this concept of health literacy, sometimes it kind of puts me off because I think, well, literacy goes both ways. You know, it's like if you wrote it or built it and someone can't use it, well, then it's not literate. The people are.
And specifically with regards to AI, I mean, I hesitate to use the term because it's, calling it a model might be more accurate because it's not really intelligent in that sense. And I think that's what some of the conversations I've had with colleagues and also with friends outside of work, it's seeing it as an intelligence is kind of like a misnomer or an inaccurate way of looking at it. I think there was a reel going around about how it couldn't count how many R's occurred in the word strawberry because it's very bad at doing maths, and it's a language model. And so seeing it as a language model allows the user or the consumer in this case to more accurately understand what it's actually doing under the hood. And I suspect the same is also true for clinicians in terms of interpreting the information that it's giving back to you. Is it just reading off a guideline, or is it trying to make an analytical conclusion based on a bunch of words that it's read?
And I just think from a consumer perspective, some of the things that you might be able to use it, because there's different types of information that you're wanting to have a look at. So, of course, I think the one that we first think about is our own health data. What do my blood pressure results mean over time? So that's the one where I think people can feel a bit like, ooh, and, needs clinical oversight, and I think there's some argument for that. But there's other information such as, if I get this type of cancer, what should I expect in terms of this many radio, this surgery, this is how long I should wait. So we've got some sense of what we can expect and actually advocate for. And talking of advocacy, I think all of us do need an advocate, like somebody who can take notes in the meeting, because when we're just hearing something that's really confronting, we won't actually retain any of it. So there's that sort of advocacy thing. And also, I just think things like the Health Direct resources are great, but imagine using that as your starting point and zhuzhing it together in a way that I can actually understand what that means. And those fantastic things like lab tests online or whatever, laboratory tests explained or whatever it is, they're great resources that already exist, and it's just about, what could we do to embrace the sort of general information needs we have as well as the clinical data.
Could I bring up an entirely different thought about AI? Because I've been thinking about it a lot lately, not so much in health, although it applies absolutely here as well. As AI starts to do the easy parts of our job and we are left over with just the hard parts, I mean, in some ways that sounds exciting. It's like, I'd really prefer to do the challenging and not the mundane. But in the places where that has happened, it's really quite stressful for people. Because if you're always dealing with something that's complex, cognitively, emotionally, everything about it is intense, and you never have the downtime to do the emails because your AI sorted that out for you. Or the easy cases, the AI did that. And I just think it's kind of an emerging workforce issue to think about, and certainly from a clinician point of view.
Yeah, I was, sorry, I just actually had a moment. I was like, oh my God, that's the best reason not for AI ever, that I would still like to have some downtime. But when you're talking about digital health systems, sort of coming back to that original point, like the clinicians, so, obviously AI is something that's coming in, but before that, virtual pathways. So actually, like we're aiming to kind of get people to the right place at the right time, and we're offering more accessible pathways, and virtual emergency departments are one of those. But they're really new. Like they're only a couple of years old, and so are urgent care clinics. And so we're still seeing, again, Jen was the one that raised this before. I was like, it's so true. We're still seeing our clinicians need to adapt to just new pathways. Like the idea of okay, we're going to send it to a virtual emergency versus an emergency. So our nurses on the phone go through a process. They know what the symptoms are. An AI, a probabilistic model prompts them to say, we think this is in this range, so they need to see a doctor or emergency. And so then it's this kind of choice between, should I send them to an emergency department, or could this be a virtual emergency decision? And so we kind of know what we think is, we know what's eligible for virtual pathways, but the nurse can still, because of their clinical judgment, override that and send someone to emergency. And so we were going, well, but why are they? Why are they overriding that disposition? And so we went and asked them, and we also asked consumers as well. And it was because they have an existing confidence based on their existing knowledge of what that emergency experience is going to look like for a consumer. And they don't have the same level of training and understanding, because they haven't worked in a virtual emergency department, of what it looks like to send a consumer over there. And so part of our training has had to be to lift their understanding of, like, well, what is a virtual emergency department like? How does it compare to emergency? And then as a result of increasing that information for our nurses, we're now starting to see our virtual emergency referrals increase. And so, you know, when we start to think about, you just kind of assume, oh yeah, that makes sense, surely they'll be fine with that. But it takes time, and it takes a few months usually for our clinicians to pick up a change and see that pushing through the way we immediately assume that it would be.
It's brilliant that you ask them. You ask them why. Yeah. So often we don't. We make assumptions.
Yeah, that's right. So we did need to go and ask why. Why aren't you doing what we thought you should be doing? Like, because we don't actually really totally understand the way this pathway works.
Can I just quickly pick up on both those points? Because I think that they're really key to the way that AI and technology impacts it's not a tech problem, but it's a policy, it's an education problem. And I know that sounds a little bit trite, but just to pick up on that point about general practice, for example, and the way that our consultations are changing over time. So, there's a whole debate about, should pharmacists give immunisations and that sort of thing. And
yes, they should.
And I'm in favour of that as well, because I do want to see the harder cases. That's what I went to, I trained for. That's where I get, the most bang for the buck for the health system as well. But the reality is, for 15-minute consultations, there needs to be a bit of flex in them. And honestly, some of those easier, quote-unquote, consultations were that flex. And then if all of them are hard in 15-minute consultation, it's just not going to work. And so we need to then look at our billing. We need to look at our policies around that, the way that we structure general practice as this changes, because there are going to be burnout issues as well. And, at the end of it, the consumer's at the middle of this, because we're sort of stressed and moving them through, and we can't actually deliver the care. And same with the education part. We need to think about, well, how do we actually prepare for this at an education level to make sure that everyone involved realises what the new pathways are and that sort of thing. I think that's a really big part of the success model.
Yeah, I think I had a question here about, our virtual care models. Are we simply just digitising old processes, or are we developing truly innovative new models? And I think that's kind of what you're talking about here, is doing things completely differently to how we've ever done them in the past. The next, I suppose, natural question is, how do we keep things people-centred, person-centred in this new virtual ecosystem?
Things or get things Sorry, I've got to ask the question, because I don't think it's person-centred. I really don't.
Right. So, that's the challenge, isn't it? We're developing these new virtual systems that solve a lot of problems, maybe more cost-effective. But how are we?
I just want to say, I do think clinicians are very person-centred, and they really care. I didn't mean that to sound so rude, because I sometimes be a bit rude, but they're sitting within a system where I know that they, we've talked a bit about funding models. We can't fund the models that we know reduce pain and suffering for consumers and families, and for the difficulty for clinicians. But there's all sorts of stuff going on, and it's not person-centred. I think you've got to follow the money.
And just another follow-on question is just, what are the infrastructure gaps that we have? Like you said, this has only been going a couple of years, like it's fairly new. What do we need to build to make it work better?
I wanted to take this one just on that idea of person care. Now, so obviously I work for Health Direct, so my answer on this one is actually, I sort of went back to me and my son. So I have a son with a chronic illness, and I was counting the other day across my family how many days did we spend in hospital last year. It was 16 days. So pretty high users. I'd say we're in the high end of healthcare use. We go to the Royal Children's Hospital. It is, I'd say, one of the best hospitals in the world. And the specialists are amazing. But recently the Murdoch Institute, and I think this is a really good way for the researchers in the room to be thinking about this as well, they're embedded in the Royal Children's Hospital, and there's lots of pieces of paper on the wall around studies you can participate in. And I was like, I better actually, do what I say that I do and participate as a consumer and as a carer in the research. And it was around how do we support children with long-term chronic illnesses for their mental health needs. And so when we're talking about person-centred care and then we're talking about infrastructure gaps or funding gaps, the thing that the system still does and the way that clinical training occurs and the way that funding occurs is we're still not connecting the hip bone to the leg bone. So my son gets treated for a certain part of his body, but there is a 50% overlap with mental health issues and depression for children with long-term chronic health issues. And then we know that there's a 50% overlap with people that have chronic health issues and mental health issues with not having sustainable housing. Because when you get sick, you can't work potentially as a parent. So then you have money issues. And so I think if we're going to be truly person-cared, person-centred, we need to, I think what the Murdoch and the Royal Children's are doing is great. They're going and asking, how can we put mental health and the mind next to the chronic illness? And then what would that look like? And then from that perspective, I'm like, okay, so then if I'm at home and I'm looking in the app, because I use Epic, it's pretty good. You can see the pathology, which is fantastic. Can't see that in my health record yet. So I look at that. But when I say, can we see a child psychologist that's specialising in this through the hospital? No. The answer is no. That doesn't exist as a service. So I have to then go find that somewhere else, and it's not in the app. And I have to, so I heard a nurse say years ago when I was working on my health record rollout, she said, at the moment, the only continuity in your care is you. So if we started to just put the pieces of the body back together, what would that mean for how we put the infrastructure back together? There is currently a directory, we run it, 150,000, and it does start to connect into mental health, but it doesn't have the social services or the community services in it. So I think there's this real, if you actually took the person-centred pieces of the body and the user journeys and then said, what is the infrastructure layer underneath, you'd start to see the gaps.
Love that. I love that answer. It captures a lot of the issues I think that everybody faces when they're dealing with a complex health system with complex problems. I'd like to open up for questions from the audience, if there were any questions for the panel.
Thank you so much for a very engaging conversation so far. This is a question to the panel as a whole. I think with AI, machine learning models, large language models, that terminology, I think, each of them have slightly different meanings, but they do get kind of lumped under AI. Some of the things that I think we run into with things like ChatGPT Health is that it's trained on this very broad-ranging data set that may not necessarily have the validation that a lot of our research that we base a lot of our clinical decisions on are kind of based on. There are some more specialized models like open evidence that have come out that are trained on peer-reviewed research articles. What are your thoughts regarding more personalized models that are specific to, I guess, use cases that can be used in the clinical setting?
I'll start, yeah. I mean, it's inevitable. So a couple of things. Yes, you're right about the sort of, I guess, the general models not being fit for purpose. Having said that, they still perform remarkably well. And as you sort of alluded to, we are moving towards more specialised models, more fine-tuned models, so I think that will come in time. I noticed that UpToDate even has its own model now. So this is a database that collates up-to-date medical information, and you can now query the LLM to bring you the data for you. I think that's positive, because a lot of the times, I'll be honest with you, as a clinician, it's a little bit eye-opening how often clinicians don't always use best evidence. Believe it or not, it's the case. And so having tools at our fingertips, and I'm very honest to my patients. I'm just going to look this up. I'm going to use the Google for Doctors, which is up to date for me. And I look it up and I say, this is what I've found, and here it is. If there's a tool that enhances that I can double check that it cites, wonderful, bring it on. I would love that. I do think there's a risk if we go too specialised that we will lose the general sense of the person. But I think more than that, we're looking again at a shift in the way that models deal with context. And I think for patients and certainly clinicians, context is key. That I need to know more about the person in order to make a good decision. What we're going to see over time is that these models are going to get better at knowing who you are. So at the moment, I'm setting up these models so I can, set up these little prompts to it to say, this is who I am, this is my background. That's quite a lot of front loading, but I get a lot better result because it knows a bit more about me. Now, not everyone's going to do that. I spend way too much time on a Saturday night doing this. No one's going to be bothered doing that. But soon you won't have to, because it will learn from the environment. It'll learn from your conversations. It'll learn from your text messages. It'll know who you are. And so that context is going to be embedded in these models. So I think even more than these sort of specialized models, I think the real sort of bang for buck is once we get more life context into the models, and they can then meet you where you are. And it's going to collate all that quantified self stuff, all that data, it's going to be in there. And so that's going to be much better than a clinician, but the clinician will have to interpret it, hopefully, with the patient. So that's kind of where I see the general model development going.
Adrian, that idea of really personalization, I think is key. You think about ChatGPT, which probably all of us use for many things. My chatty knows me and can bring up things that will, that would not be the same if you asked the same question. And as we build the health that same way, I just think that it gets quite exciting to me what's possible, that no clinician could hold all that in their head for every patient they've got. But we could hold it in our pocket.
Myron, did you just want to make a comment?
Yeah, I just want to say on the topic of custom models, I have colleagues who are medical students, and we want to retrieve information from guidelines. We're all kind of making custom models in the use of Notebook LM. And that's just an open source thing. You put a bunch of guidelines in there. You want to retrieve information on how a particular condition may be addressed. And that's just a really consumer-friendly, easy way to use RAG, or retrieval augmented generation. You just put stuff in there and you pull it out. It's basically a search thing, but it's way more efficient than relying on the entirety of human knowledge that ChatGPT may be sitting on top of. It's definitely a lot faster.
Unfortunately, I'm very sad to say I have to wrap up this conversation because we have another session commencing at 11:30, but it's been a really fascinating discussion. The hour has just flown for me. We covered a lot of ground. We didn't get to everything that we'd planned, but I think we got through a lot of it. I want to thank you all for being so engaged and really riffing off each other. It was just a really wonderful panel. And so can you please join me in thanking our panel today?